So good afternoon. Hope everyone is doing well. I'm Kevin Thomas. For those of you all who don't know me, I'm a DCRI faculty member on the cardiology side. And it's a great privilege today to be able to introduce our guest speaker, Carlos Rodriguez. So Dr. Rodriguez is an associate professor of medicine with tenure in the Department of Medicine and the School of Public Health Sciences at Wake Forest University, so just down the road. He was born in Santo Domingo, Dominican Republic, and grew up in New York City. So he received his MD, MPH degrees from Columbia University, and also trained in internal medicine and cardiology at Columbia as well. He joined the faculty there and was faculty there, very successful with research publications and funding, and many directorships until 2011 when he decided to relocate to the great state of North Carolina. And he joined faculty in Winston-Salem at Wake Forest. A year after arriving at Wake Forest, he was offered and accepted and given a tenured position, and has continued to do wonderful research in the world of health disparities as it intersects with epidemiology. So obviously appropriate to be giving a research conference here today. So his research interests primarily focus on improving the health of Latino Americans in the U.S., and he's been a prominent contributor to many large epidemiologic studies that have focused on minority health, including NOMAS, the Community Heart Study, the multi-ethnic study of atherosclerosis, the Jackson Heart Study, among several others. He currently serves in many capacities on a national level. He's been a representative and participant in several NIH study sections, and currently he's the chair of the American Heart Association Mid-Atlantic Affiliate Research Committee. So that is obviously important to many of our junior faculty members and fellows who oftentimes will apply for funding through that particular mechanism. Also, he's the chair of Genomics, Translational, and Biological Epidemiology and Observational Epidemiology, the Clinical Science Peer Review Committee. He's also the chair of the Hispanic Working Group in the multi-ethnic study of atherosclerosis. So please join me this afternoon in welcoming Dr. Rodriguez.
Thank you. Thanks, Kevin, for those kind words. It's truly an honor and a pleasure to be here. I want to thank Duke and the DCRI for the invitation to give a talk here. It really is a pleasure. So today I'm going to talk about cardiovascular disparities, and specific to that, the echocardiographic study of Latinos. So the first thing, I want to point everyone to this document. This document is the first ever scientific advisory from the American Heart Association on the status of cardiovascular disease and stroke among Latinos in the United States. There's never been such a document. You'd think there had been, but there hasn't. First ever. I was lucky enough, fortunate enough to chair this document along with many esteemed and distinguished colleagues, some of whom are cardiologists, some names whom you may recognize in the academic circles. But I want to point everyone to look at this document, download it, read it. We certainly put a lot of work in it, and a lot of what I'm going to talk about today stems from it. So, the U.S. population. What about the U.S. population right now? These are some recent federal statistics on the U.S. population as it stands. And I want you to realize that currently Hispanics, Latinos, and the term Hispanics and Latinos I'm going to use interchangeably, okay? So don't get confused. Just follow me along. Hispanics currently make up over 17% of the U.S. population, okay? That makes them the largest ethnic minority group in the U.S. You can see from the recent statistics, the light purple bar is 2014 statistics. The dark purple bar are projected estimates to 2060. Right, 45 years down the road. So focusing on the light purple bars, currently Hispanics are the largest ethnic minority in the United States. They form a larger proportion of the American population, larger than African Americans, larger than Native Americans, larger than Asians. Okay, so definitely an important group with regards to size that we should pay attention to. There are 55 million Hispanics. The 17% translates to 55 million Hispanics in the United States. That's larger than the population of Canada, if I'm not mistaken, larger than the population of Australia. So this is a huge, huge number of people that impact us, impact healthcare, and that, again, we should learn more about, become more familiar with. And we all know the U.S. is projected to become more diverse. You look here at current estimates, we're at 37, 38% minority population. It's projected that by 2060, over half of the U.S. population will be minority. Okay? So, and of this minority, Hispanics are expected to make up 25% of the U.S. population by 2050. That's 1 in 4 persons in this room or elsewhere will be Hispanic. So as the country becomes more diverse, and with the knowledge that Hispanics form a substantial part in numbers of that diversity, we need to become more educated, aware of the health issues in that population. So let's talk about Hispanics and learn a little bit about their state in the U.S. So Hispanics, these are again U.S. statistics, federal statistics, with non-Hispanic whites in the yellow bars and Hispanics in the red bars. When it comes to median income, Hispanics in the U.S. generally have a lower median income. You can see the disparity there. Hispanics are less likely to have a college education, okay, about more than 2 times less likely to have a college education, significantly less likely to have a high school education compared to non-Hispanic whites. Hispanics are more likely to be in poverty. And interestingly, not too different, at least not statistically different, with regards to being unemployed or employed. So even though Hispanics are not too different with regards to employment, there's still a wide disparity in their median income and in their socioeconomic status. When it comes to healthcare insurance, these are again U.S. statistics. Hispanics are twice as likely to be uninsured or to lack health insurance compared to non-Hispanic whites. And this is, the white bars indicate, the green bars indicate being uninsured. And you can see that Hispanics are twice as likely to be uninsured. The blue bars indicate public insurance, and that's Medicaid or Medicare. The white bars indicate private insurance. When it comes to public insurance, it's very similar between non-Hispanic whites and Hispanics. The big disparity is in private insurance, where you can see the gap there. And again, going back to employment is very similar between Hispanics and non-Hispanic whites. So despite similar rates of employment, Hispanics are disproportionately uninsured, as well as disproportionately with lower socioeconomic status. And that translates to Hispanics being 3 times as likely to not have a regular healthcare provider. These statistics, this figure, this graphic is from NHANES data, and it's looking at the lifetime risk of acquiring diabetes. So in looking at the lifetime risk of acquiring diabetes, and again, this is from NHANES, Hispanics are in the red lines here, and going from birth to old age, you can see in men and in women, compared to any other race ethnic group, Hispanics carry the highest risk of developing diabetes compared to any other race ethnic group in the United States. And this is also data from NHANES, where you can see that Hispanics carry, and this is true in men and women, compared to non-Hispanic whites, Hispanics carry more diagnosed diabetes, as well as more impaired fasting glucose, or pre-diabetes, what we call pre-diabetes. So Hispanics carry much more of this in men and women, as you can see here in this graphic. And what about overweight and obesity? Again, data from NHANES, looking at non-Hispanic blacks, non-Hispanic whites, and Hispanics, Mexican Americans in particular. You can see that Mexican Americans have the highest rates of obesity, of being overweight, compared to blacks and non-Hispanic whites. And the rates of obesity are higher in Hispanics compared to non-Hispanic whites, and very comparable to those seen among non-Hispanic blacks. What about cholesterol or dyslipidemia? So when you look at cholesterol and consider cholesterol, you have to look carefully. This is data that we obtained from a study in northern Manhattan in New York, NOMAS study. We looked at a tri-ethnic population, non-Hispanic blacks, non-Hispanic whites, and Hispanics. When we looked at dyslipidemia, if you look at LDL, LDL is not significantly different between non-Hispanic whites and Hispanics. Hispanics shown here in the white bars. And the same thing with total cholesterol. But I want you to look at low HDL and high triglycerides. You see that Hispanics are significantly more likely to have low HDL and high triglycerides compared to non-Hispanic whites and non-Hispanic blacks. This is a pattern of dyslipidemia that we call mixed dyslipidemia. Okay, and it's a particularly dangerous type of pattern. This type of result was also shown in the IRIS study, the insulin resistance and atherosclerosis study, that also had African Americans, Hispanics, and non-Hispanic whites. You can see from their data that HDL levels were significantly lower among Hispanics compared to African Americans and whites. Triglyceride levels were higher among Hispanics compared to African Americans and whites. But again, this pattern of dyslipidemia, what it leads to, it's a smaller size, more dense, low density lipoprotein particle, which is more atherogenic, more apt to cause disease. So my whole point with this is that when you look at Hispanics, if you focus only on the LDL, and that's really where most people's focus is, on the bad cholesterol, the LDL. If you focus only on LDL, when you look at them as a population, when you look at Hispanics as a population, they may not seem at high risk because their LDL is pretty much not different from other groups. But when you start realizing that they actually carry this more atherogenic dyslipidemia pattern, then you realize that Hispanics carry a lot more atherogenic risk, despite the similar LDL levels to non-Hispanic whites. All right, so I just given you a snapshot of Hispanics in the United States with very low socioeconomic status, a lot of cardiovascular risk factors. But look at this data. This is, again, federal data looking at overall mortality or life expectancy and heart disease mortality. Hispanics actually have longer life expectancy than non-Hispanic blacks and non-Hispanic whites. Okay, they actually live longer and they die less from heart disease. Their heart disease mortality numbers are lower than non-Hispanic whites and non-Hispanic blacks. So given everything I showed you, what the heck is going on here? This is what's known as the Hispanic paradox. An important concept, an important epidemiological concept that, in my mind is not conclusive and it's controversial. It has been supported by some studies, especially when some of the studies that first put it on the map, including this JAMA article from Sorley, that put this paradox concept on the map, that despite this high burden of risk factors and low socioeconomic status, Hispanics seem to live longer or die less from heart disease. Okay, so it's supported by some studies, as I mentioned here, but it's also been refuted by others. There's some studies, the San Antonio study, that was a prospective study, particularly in Mexican Americans, comparing them to non-Hispanic whites, showed actually higher cardiovascular mortality compared to in Hispanics compared to non-Hispanic whites. And the Corpus Christi study showed no difference in cardiovascular coronary heart disease mortality between non-Hispanic whites and Hispanics. So these would go against the paradox. Also, when you look at rates of premature deaths from national data, it looks like Hispanics die more Hispanics die from premature heart disease than non-Hispanics. So that would go against the paradox. So in my mind, this is not a conclusive thing, a conclusive concept. But what you have in the research and epidemiological world is you have people falling on one side of the fence or the other. There's some people who wholeheartedly believe in the paradox, and some that do not. And I think it's important to have a balanced approach when studying this and know both sides of the equation. Okay. Some recent data, and this is a meta-analysis that kind of put together all of these prospective studies that had compared cardiovascular disease mortality in Hispanics compared to non-Hispanic whites in the US. And actually, in this meta-analysis, you can see in the graphic a lot of the hazards ratios or the relative risks falls on the left side of the equation, being protective, but a lot of it also crosses the line, which means it would be non-significant, which would go against the paradox. But when all the studies were put together, they basically came up with the number that Hispanics had a 51% lower risk of cardiovascular mortality compared to non-Hispanic whites, and a 34% risk of total mortality compared to non-Hispanic whites. So this meta-analysis would sort of support the paradox, and this is recent data. But again, I think there's a lot of limitations to this. We don't know how socioeconomic status moderates this. There's a lot of heterogeneity in these studies and how Hispanics were defined, and the whole process of acculturation is not taken into account, which I'll discuss a little later. So in my eyes, the Hispanic paradox is kind of a mixed blessing. It's really not one-sided thing. Now, there's a lot of people who think it's just a pure blessing. Maybe Hispanics, maybe we have something that is some type of protective factor that we can learn about and extend to the general population. You know, on a positive note, the fact that we don't know what this factor is kind of highlights how little we know about the Hispanic population and sheds a spotlight on Hispanics, that we need to study them, we need to learn more about them, is the mechanism for the paradox, if it's true, is the mechanism nutritional? Is it something with the diet or the water we drink? Is it something psychosocial? Is it something genetic? We don't know. But it does kind of put a spotlight on the Hispanic population, and that's good. But I think it's also a problem because it perpetuates a notion that you have a certain segment of the population that is at low cardiovascular risk. So you can really confuse a lot of people in how to be aggressive in treating the Hispanic population. Some people may be confused. Oh, they're not really going to die as much, or they're going to be very resilient. So okay, they got a lot of problems, but I'm not sure if I should be that much aggressive in treatment. So I think the paradox may kind of confuse or dissuade people about what to do in terms of how to care for the Hispanic population. And obviously, the paradox was based mostly on data that came from Mexican Americans, because Mexican Americans, as you'll see, comprise the largest proportion of Hispanics in the US. And Hispanics are often aggregated as one group, but in actuality, if this paradox exists, maybe it doesn't apply to every Hispanic group equally. So there's still a lot for us to learn. So this is just showing the geographic diversity of Hispanics, over 31 countries in Latin America, shown here. And from Mexico, Latin America is also in the Caribbean, part of the Caribbean, with Dominican Republic, Cuba, and Puerto Rico, as well as Central America and South America. And when you look at Hispanics in the United States, you also see that type of diversity. Yes, the majority of Hispanics in America, in the United States, are Mexican Americans, as you can see here, but there is a significant portion, 14%, that are from Central and South America, and then 9% from Puerto Rico, 6% from Cuba, and 4% from the Dominican Republic, which is where I'm from. And these together we collectively refer to as Caribbean Hispanics, which make up 19% of all Hispanics in the US. And interestingly, with Hispanics, this graphic is meant to show a little bit about the geographic diversity within the United States. One of the things that is important to acknowledge about Hispanics is that there has been differential immigration patterns within the United States. So you see Hispanics only in certain parts of the United States. You see the darker and lighter shaded purple areas are where you find Hispanics, mostly in the Northeast, Florida, a little bit in the Midwest around Illinois, and then a lot in the Southwest and West. And then depending on what part of the United States you are, you may get a different flavor of the Latino population. So it's important to acknowledge if you are in the Northeast or in Miami, you may see more Caribbean Hispanics, whereas if you are in the Southwest or the West, you may see more Mexican Americans. So it's important to acknowledge that where we are, the Hispanics that we come in contact with, we may be only getting a slice of the vast Hispanic population. So it's important also not to have, generalities as we try to learn about the Hispanic population, that we extend to the little slice that we see in our own backyard, extend it out to the entire United States. Okay, and this is one of the things that we cover in that circulation article about the heterogeneity and the historical context of the different Hispanic groups in the United States. Along with that heterogeneity, there is racial heterogeneity in Hispanics. And this is an important concept that people kind of had a hard time grasping initially, but is that being Hispanic is not a race, it is an ethnicity. Okay, so a lot of times some people think of it as a race, but it's not. And there's a concept in the US about about being only white or black. And that's really a concept that's not familiar to Hispanics. It's not culturally familiar. And thus, it kind of complicates research when we try to fit a square peg in a round hole and try to put our own social framework and paradigm and apply it to a culture that is not the culture here in the United States. So it's important to acknowledge that. Because people will look at me and they won't realize that I'm Hispanic and that there are many more that look just like me. Some people will tell me that they thought all Hispanics were Mexican Americans, but they're not. We are an admixed population of varying racial admixture. And what you have with regards to racial admixture will vary depending on what Hispanic group you may encounter. This is genetic data, genetic ancestry data, where you see in the blue area is Native American ancestry, the green area is African or West African genetic ancestry, and the red area is European ancestry. When you look at Mexicans and folks from Ecuador or Colombia or Central South America, you see that there's more of a genetic admixture pattern where there's mostly Native American and European ancestry. Whereas if you look more at Caribbean Hispanics, such as those from the Dominican Republic or Puerto Rico, you see more African ancestry and European ancestry. And you see some Native American ancestry, but not as much as in Hispanics from Mexico or Central or South America. So, this is important because one of the things I try to do is to try to see if being black and being Hispanic here in the United States, does that affect the disease process? And this is a study that we did in Northern Manhattan where we did a lot of educating to Hispanic participants as to what we meant by black and white. That it wasn't that we were saying African American or Caucasian, but trying to educate Hispanics on the concept of race as it is formulated here in the United States. And in getting that information, we also measured a biological, physiological measure in ambulatory blood pressure, 24-hour blood pressure. And we saw that being Hispanic black actually carried almost 3 times as likely a risk for having an abnormal 24-hour blood pressure pattern. So there was more non-dipping among Hispanic blacks compared to Hispanic whites, sort of coming to the conclusions that maybe Hispanic blacks and Hispanic whites may have more similarity, at least in the prevalence of abnormal 24-hour blood pressure to their non-Hispanic counterparts than to each other. So race may be an important modifier of disease among Hispanics, but it's something that is not studied and not appreciated because of the complexities I mentioned. So with all this, I'd like to bring you to Echo's Soul, which is my latest research endeavor and where my research has culminated. And this is, I want to first direct you to this paper in the Journal of Ethnicity and Disease. This paper is going to describe the methodology, the rationale for this study, and why I felt it was important to do this study to try to learn more about the Hispanic population and what it could mean to us understanding better the health of all Americans through this type of knowledge. So Echo's Soul is really based on this huge landmark study called the Hispanity Community Health Study, or the study of Latinos. This study, Soul, and Soul in Spanish means sun, is the largest epidemiologic study of Hispanics in the United States. It's a huge study. Some people call it the Hispanic Framingham, but it's meant to gather data on 16,000 Hispanic participants, okay, from 4 areas in the United States: Chicago, the Bronx, Miami, and San Diego. UNC is the data coordinating center, and to get all the subgroups, all the Hispanic subgroups represented. It's important to have these geographic areas because remember I spoke about the different geographic immigration patterns in Hispanics. So this, by having these different field centers, all the Hispanic groups are represented. And there's comprehensive baseline data, medical exam, EKG, ABIs, sleep studies, pulmonary studies, a deep battery of psychosocial, socioeconomic assessment, dental exams. I mean, this is a lot of data. And what we added to that with my ancillary study was echocardiograms, cardiac imaging, based out of Wake Forest. So again, EchoSoul is an ancillary study based on the larger huge soul study, and I'm the PI of EchoSoul. It's a 4-year study funded by the NIH, and the goal was to recruit 1,800 Hispanic participants above the age of 45, represent all the subgroups. So we recruited from all of these field centers across the US, and to get baseline data on over 80 different echocardiographic variables. And we wanted to characterize cardiac function among Hispanics, and we wanted to determine how psychosocial factors impact on cardiac structure and function among Hispanics. So I won't bore you with some of these logistics, but this is just how we had to build an echo lab, a core lab. You know, we had to do site visits, took a lot of work, had to do site visits, because this is where we were getting the data acquisition at each of these field centers. Had to do site visits, train sonographers, certify them, get a manual of operations, do a lot of QC at our own Wake Forest core lab, as well as at the field centers. Had to devise a system to get that echo data electronically transferred from Chicago, Bronx, San Diego, Miami, transferred to Wake Forest. And we did that by basically connecting the echo machines, the ultrasound machines, through a secure network to a PACS, a secure server at Wake, where then we could retrieve the study for analysis and interpretation of all the echo variables that we were interested in. So, you know, we started that process early in 2011. You know, we had to customize the software for the data interpretation. We had to build an internal database for tracking of all the studies in and out. And finally, by the fall of 2011, we were ready to enroll our first participant, which was very exciting. And obviously through all this, we had to maintain conference calls with all of the investigators at all the sites to make sure everybody stayed on the same page. Our protocol for data acquisition was pretty routine, all the same echo variables that you become familiar with in the clinical world, and a very similar echo protocol to what's done clinically with just a few tweaks in it. And for those of you who may not have seen an echo before, this is what it looks like. It's a fantastic tool. You get real-time moving images of an actual organ in the body. You can get so much rich anatomic and physiologic data from this study. This is parasternal long axis view. We also did the short axis view. From the short axis view, what was unique about this study, we extended the echo protocol so we could view the base, the middle of the heart, and the apex of the heart. That gave us new, unique information that some other studies did not have. And we got hemodynamic information using Doppler, spectral Doppler, and tissue Doppler. We also looked at left ventricular outflow velocities, both across the outflow tract and across the aortic valve, and also for IVRT, so we can time intervals with the cardiac cycle. And we did a comprehensive assessment of the right ventricle. So we didn't just focus on the LV, we also looked at the RV for all different types of parameters. And what we ended up is with data in these large buckets of cardiac structure, left ventricular function, a lot of echo variables on left ventricular diastolic function, a lot of right ventricular structure and function variables. We also obtained valvular assessments and some other measures like aortic root and the presence or absence of pericardial effusion. On top of that, we also obtained myocardial strain, which is this new novel technique which kind of lets you assess cardiac function by actually seeing how the myocyte element shortens and lengthens throughout the cardiac cycle. So this is kind of a new technique which we added to our study. So the study went great, recruitment went great, we exceeded our milestones. Our data quality was rigorous. This just shows you that less than 5% of the studies were deemed poor and less than 2% are missing our primary outcome measures. And we assess image quality throughout the study in a variety of ways. This is showing you our QC data. And again, our design, how we made it balanced so that we could represent all of the subgroups across all of the centers. And let me see if I can run quickly through some of the preliminary findings. We have several preliminary findings, but the cohort is mostly female. We recruited 1,818. They're mostly middle-aged, only 21% greater than 65. A lot of hypertension, a lot of pre-hypertension, a lot of diabetes, a lot of pre-diabetes, as you can see here. So, and a lot of prevalent obesity. And there was some differential variation in these things among the Hispanic groups. It's mostly a low-income, low socioeconomic status group. You can see that more than 50% are making less than $20,000. Preferential Spanish speakers in close to 90%, and mostly an immigrant population, but they've been in the U.S. for a long time. More than 80% have been in the U.S. more than 80 years. There's a lot of LVH, left ventricular hypertrophy in the cohort. There's a lot of abnormal LV geometry. This is looking at the cavity of the heart and the thickness of the heart muscle. Over a third of the EchoSol population had abnormal LV geometry. We showed an interesting association where the number of live births was associated with diastolic dysfunction. And we showed that women, Hispanic Latino women with more than 5 live births had a 3 to 4 times higher risk of having diastolic dysfunction, abnormal cardiac function. So parity may be an underappreciated risk for cardiac dysfunction. We looked at how the echo parameters that have been thrown out there that have been used for decades have not been based on any studies that include Hispanics. And we showed how some of the reference values that are used clinically may actually overestimate disease in Hispanics. We looked at the prevalence of systolic dysfunction and diastolic dysfunction in the Hispanic population that we studied. And systolic dysfunction was prevalent in 3.6%, varied a little bit among the groups, with Mexicans having the lowest prevalence, and systolic dysfunction was highest among men, and really was not too different among either young Hispanics or old Hispanics. Diastolic dysfunction was highly prevalent. Over 50% of the Hispanic population that we studied had abnormal diastolic function. It was more prevalent in females, and it did significantly increase with age. Importantly, we also tried to assess how much asymptomatic or preclinical or unrecognized cardiac dysfunction there was in this population. And actually, 50% of the population had subclinical or unrecognized left ventricular diastolic dysfunction. So there's a lot of the population that was carrying around cardiac dysfunction. And among those with cardiac dysfunction, 96% of those, their cardiac dysfunction was subclinical or unrecognized. Diabetes, worsened glycemic status was associated with abnormal cardiac parameters. And interestingly, we saw the change start even in the pre-diabetes stage. And again, this is important, as I showed you before, Hispanics carry more pre-diabetes than non-Hispanic whites. It's been shown in NHANES, and we also seen that in SOUL. So this is important that cardiomyopathy seems to begin early among Latino diabetics. Acculturation, I feel, is important and understudied as it connects to cardiac structure and function and possible risk for heart failure. Acculturation is complex. You have stress with acculturation. You have a change in health behaviors and maybe a moderation with social support that can lead to altered cardiac structure and function and ultimately to heart failure. And what we found in our study is that increasing years in the US as a measure of increasing acculturation, increasing years in the US was associated with more abnormal cardiac parameters. And when we looked at Latinos that had been in the US longer, those Latinos that had been in the US longer had more cardiac dysfunction than those who had been in the US for less amount of time. So significant association there. And going back to the echocardiogram, I mean, why focus on these echo variables and echo parameters? Well, echo parameters in and of itself, independent of clinical parameters, echo variables can predict incident heart failure. This is data from the Heart and Soul study showing that if you look at individual echo variables and put them in a composite score, you can predict incident heart failure. The higher the score is, the more your risk of incident heart failure. And when we applied this score to the Echo Soul population, we got actually over 50% of the cohort had a score that was over 3. That means that over 50% of the Echo Soul cohort had a higher than normal risk for incident heart failure. Okay, and then when we tried to look among the Hispanic groups who had the highest score and the most risk, over 70% of Puerto Ricans were more likely to have a risk score greater than 3, compared to with Mexicans having the lowest heart failure risk score. So what are the conclusions here? Left ventricular hypertrophy is prevalent. Abnormal LV geometry is prevalent. Diastolic dysfunction abnormalities are prevalent among the Hispanic Latino population that we studied. And a significant proportion of the cardiac dysfunction that we saw was preclinical or unrecognized, which means that in clinical heart failure, we're just catching the tip of the iceberg when it comes to the Hispanic population. And there's maybe a differential risk among the Hispanic groups, but this has to be further studied and further looked at. And again, why is this important? Heart failure, for those of you familiar with heart failure works in a continuum. We go from risk factors to preclinical cardiac abnormalities to then full-blown clinical heart failure. And what we saw is that diabetes in Latinos impacts stage B heart failure, which is this preclinical cardiac abnormality stage. Acculturation impacts cardiac structural and functional abnormalities. And because Hispanics have a high prevalence of these stage B heart failure abnormalities of structure, cardiac structure and function. And as I showed you in the baseline characteristic slides, Hispanics also have a high prevalence of stage A risk factors. They are at high risk for clinical heart failure. So it's very likely, given all of the epidemiologic data that I showed you about the Hispanic population at the beginning, that Hispanics will impact the epidemic of heart failure as it continues in the United States. It will impact healthcare. So what do we want to do? What are our next steps? We want to collaborate with everybody, everyone in this room. We want to have more people use the data, more people work with us to uncover answers, generate new questions. And I want to invite everybody to look at the Hispanic Community Health Study and SOUL website. Very easy to navigate. Good place to start to get information about SOUL. Obviously, my presentation focuses on EchoSOUL, but EchoSOUL is only one of several ancillary studies that you see listed here. So you don't have to necessarily just do cardiac structure and function. There's a lot of other work going on sociocultural things, youth studies, sleep studies, just a wealth of data, genetic data that you can all participate in. And here's the website address, my email, my phone number. You can contact me if you have any questions. I'd be glad to help you and help you navigate the process, or point you to someone who knows an answer if I happen not to know the answer. So with that, thank you all for your attention, and thank you for coming.
Yes.
Well, I am Hispanic. I have a background of Black grandparents and Caucasian Black grandparents. And it's very interesting to see that you are making this study within Hispanic people instead of comparing us to, other groups. Now that all this information is going to be available, what kind of health policy do you think can be designed?
Yeah, so you've alluded to what we hope is the overall goal. It may be a little too early to say that, or to really grasp that answers at that question, because I think there's so much for us to learn. One of the things that we identified in that article from Circulation about cardiovascular disease and stroke in Hispanics are the areas that we need to address that will help us to generate policy. Because we just don't know. There's so much that we don't know. Even this whole paradox question, I think, is like a cloud that looms over Hispanics. And, like I said, it may be something great. It may be something not so great if we're kind of if this is confusing people on what to do about Hispanics. But we need answers, and that's what our study hopefully will provide. Not just, our study with EchoSOUL, but SOUL in general, the big study. And so we need answers, and we need more people like you to be involved and work with us. Yes?
So you mentioned that there are a number of sociodemographic factors that also are included in the study. And my question was, is stress one of those? And have you looked at stress over time and how that affects the findings that you see in EchoSOUL? Particularly around the issue of acculturation, right, with the Hispanic paradox, and seeing the changes over time. Is it possible that one of the factors that are external acting on individuals over time is the stress itself?
Yeah, that's a great, fantastic question. So my question back to you is, how do you measure stress?
In sociology, they have a number of these different sort of stress surveys that you can utilize. But you're right, there can be debates about the appropriate way to do it. And the other question, I guess, around this sociodemographic fact, things that you use, is it culturally appropriate in the way the question's asked, given the population that you're dealing with as well? So I guess it's pretty complicated in that respect.
Right. So yes, there is stress measured. There's a questionnaire that was administered to all of Seoul. And we will be looking, we have proposals that we want to generate to look at stress within Echo Seoul, and maybe you can help us with that. Be happy to work with you with that. All of the questionnaires that were administered in Seoul, they were made specifically to be culturally appropriate to the population. That was one of the big deals in the implementation of the study. But there is a stress questionnaire. Going back to the question that I posed to you, how do you measure stress? So is this questionnaire the one-all and be-all answer to give you the information that you need about stress in this population? I don't know. One of the ways that I was looking at stress is with ambulatory blood pressure. And this is one of the things I was looking at sort of from a more physiologic type of perspective. Ambulatory blood pressure, you look at 24-hour blood pressure, your blood pressure is supposed to go down at night. So blood pressure has a normal diurnal type of pattern. People who are stressed, their blood pressure kind of stays up at night. So their blood pressure, instead of having a nice diurnal dip, their blood pressure stays up. So one of the things that's been postulated in the ambulatory blood pressure literature is that abnormal blood pressure pattern or non-dipping is a marker of stress, or can be a marker of stress, among other things. So, how you measure stress, I guess what I'm trying to get at is probably there's different ways to tackle that question, and we can be more creative about that. Yes.
You mentioned that your study suggested that some of the normal echo parameters might be applicable to your population. Then you also mentioned that you had a lot of subclinical heart failure. Is there any plans to follow these patients and see who develop overt clinical heart failure and whether your predictions hold true?
Yes. That's actually in our main plan. We want to track progression. And I think, interestingly enough, one of the things that we don't know and that makes this important, given this whole thing about the Hispanic paradox, will heart failure develop in this population? So for whatever reason, I showed you this consistent census data that Hispanics live longer and die less from heart disease than other race ethnic groups in the US. So, will they develop heart failure despite the overwhelming risk factors that they have? Will they develop heart disease? And yes, we will track progression, or that's in our plans to get funded to track progression and to ascertain that.
I have a question. Do you think the Hispanic paradox was developed mostly because the early studies only included Mexican Americans versus now Seoul, you're showing there's significant difference between Caribbean Americans and I can't remember what else you have there, but Mexican American, do you think that's the reason for it? Or in part?
No, that's my personal view, okay? But I tell you, I've spoken to other Latino researchers, and we have a lot of great colleagues, but there's some people who really feel that the Hispanic paradox is really true, and that Hispanics really carry some type of great benefit that extends to everybody. And like I said, maybe it's a blessing, maybe it's there, and we need to learn more about it. But if it's not, then all that it's bringing is confusion. So I think we need to look at the Hispanic paradox with a balanced approach. My hypothesis is that, yes, I think that there's a differential risk pattern among the different Hispanic groups, and that may explain a lot of it. But also, acculturation, how long Hispanics have been in the United States may also affect the paradox.
Yeah, that was going to be the point that I made, is like, I'm wondering if you follow that over time, will that begin to change and flip as Hispanic Americans pick up many of our bad habits here? So But this is wonderful, terrific. Thank you very much for this. Do you all have a repository of blood samples that would allow for assessment of biomarkers and markers of inflammation like interleukins and things like that? Is that part of the study as well? Because I think that'd be, you were talking about stress and being able to measure, cortisol levels and norepinephrine levels and things like that would be tremendous and very interesting. And give you a concrete, objective assessment of stress and the physiological effects it has on the body.
Yeah, I think that's a great question. There is a repository of blood that's stored, and it's available for a creative study to add more biomarkers. Right now, the only biomarkers in the study are CRP and some HCV types of blood data. So I think that there's room to add a creative ancillary study that's going to look at biomarkers, like you said, with a nice hypothesis centered either around stress or inflammation, and how biomarkers can help us delineate that, investigate that further. So yeah, I'd be happy to work with you or someone else who may have that type of idea, or point you to some other people who can help develop that idea. So I think that's great.
We have a final question? Yes.
One of our recent studies was looking at depression and how it affected African Americans. And I think that being Puerto Rican, we were voted one of the happiest people in the world. And that has a huge impact on, diseases. I know some of my family have lived up to 114 years old. But I was wondering what the generational gap was going to be like, because my 21-year-old is nothing like me growing up in Puerto Rico, and the differences in culture are huge. There's a disparity.
So this database of Hispanics is great. We have first generation, second generation, third generation in the database. So you can look at a question like that, and you see in third generation Hispanics, many of them don't even speak Spanish. It's a whole different pattern, social pattern. But you're right, when it comes to kind of the happiness in the Latino population, you can probably, if you remember the diagram that I showed with acculturation, social support was kind of there as a moderator. I mean, people in Latin America, someone from Brazil back there, you can test, we're happy people in Latin America. We're just happier. So maybe that has something to do with the health advantage. If there is a health advantage, maybe that has something to do with it. We don't know, right? And maybe that's lost over time. We also don't know. But
And depression medication.
yes. It's a good question.
Thank you all very much. Thank you, Dr. Rodriguez.
Thanks for having me.